Good morning. I would like to introduce Michael Reeser, RRT from Millennium Respiratory, who will be sharing on ventilation.
Hi, good morning. My name is Michael Reeser. I'm with Millennium Respiratory Services. I'm sure I know some of you already, but if not, I'm the senior therapist for Millennium Respiratory. And today we're just going to be discussing a little bit about ventilation and some clinical aids to help you along that journey, but a little bit about Millennium Respiratory Services before we get going. We're a hands-on clinical respiratory company providing care in all areas of respiratory home care. We service everyone from pediatric population to adult patients. We use non-invasive and invasive ventilation to do that. We specialize in neuromuscular disorders. We like to follow Dr. Bach's theory for non-invasive ventilation. He is up in Newark, New Jersey, and we implement the use of non-invasive respiratory aids to facilitate breathing and coughing. This helps minimize respiratory complications, most importantly, reducing the number of hospitalizations, allows the patient to have quality of life. There was an interesting study back in 2002. It came out and basically just saying how effective is Bach's method in reducing hospitalizations of children with spinal muscular atrophy. And you can read the tab there, but basically it really slowed the hospitalizations. For example, the children average 1.53 hospitalizations per year by the third birthday. And that rate dropped to 0.33 for the age of 3 to 5. And the further drop after age 5 to only 1 hospitalization of more than 20 years. I guess the take-home message with that is, with those aids of ventilation, they stayed out of the hospital. And that's, especially with things that are going on now with COVID, that's super important. So the aids definitely work if you use them. So the next slide here is basically going over what some of those aids are and the guidelines that we use to know when to initiate those aids. And there's some pictures there on the screen. That top one there is a Philips Respironics product. It's a cough assist. The next one down is a Trilogy 100 by Philips Respironics. A little bit older vent, but definitely effective, is the LTV 1150. And then underneath that is a ResMed Astral 150. The ventilators, I get a lot of patients ask me, well, which ventilator is the best? And that's actually a really good question. I know we're getting a little bit off topic here, but I just want to address that because it comes up quite frequently, especially now with the recall with the Trilogy 100. There's not any one ventilator, I think, that's over another. They all do the same thing. They're pushing air in and out of the lungs. It's measuring those flow dynamics and giving us some information on how the breathing is going. But it's kind of like an automobile. They all kind of get you from point A to point B. It's just the little intricacies that are different, but they all do the same thing. And I wouldn't say that one's better than another. As far as my own personal preference, I kind of take a look at the patient and see if a patient is invasive or non-invasive. That may help guide me to a certain device. But so if you have any further questions, definitely feel free to ask those at the end of the presentation here. So one device that is super, super important is the N-exsufflator, and that's the generic term for a device like the cough assist. Cough assist is kind of like it is the brand name that Philips Respironics has for that device, but the generic name is the N-exsufflator. And basically that word means the air goes in, the air comes out. And so when you come into the clinic, the multidisciplinary clinic, one thing that the respiratory therapist will do will measure your cough flow. They'll have you cough into a device. And once those flows drop below 270 liters per minute, or strong indications of choking on food or secretions are present, then the doctor may elect to go ahead and order that for you. The respiratory therapist would then bring that device out and show you how to use it. Very effective. The other thing that the cough assist or an exsufflator does is it hyperinflates the lungs, especially the bases, which are the bottoms of your lungs. And those are the hardest parts to keep inflated. And that helps to prevent any type of respiratory infections, or at least helps with that. Not necessarily prevents it, but it definitely keeps things moving in the right direction towards the head, so you can get them out of your lungs. Great device. The other way that I like to use that device is, there's a lot of anxiety with a disease like ALS. And sometimes I've had patients tell me, I just can't get a deep enough breath. Boom. I use the cough assist on the inhale only. Those of you who have the cough assist, if you constantly use it on inhale, exhale, and you really don't have any secretions, try it just on the inhale. It's a nice smooth breath delivery. You can just take the mask off or the mouthpiece, whatever you're using, before it goes to exhale if you want to try it, just to see how that feels on the inhale only. If you need some help with that, just ask your respiratory therapist and they'll be happy to help you. Non-invasive ventilation, we'll move on there. Next part down there. So a lot of patients want to know, well, when do I begin that? My thought process is once the doctor elects to go ahead and start you on that, the sooner we get that going for you, the better. And I'll have some patients say, well, I don't have any symptoms. And I get that. Nobody wants to be on a ventilator. But I will say this, it's easier to kind of get the hang of something while you're feeling decent rather than waiting to the very end there. So, start as early as possible. As soon as you start having symptoms and the doctor feels it's necessary, the doctor's writing the order, they're using their expertise to help guide that. So the sooner the better with that. But basically we're looking for decreased vital capacity. That's where you blow in the spirometer of less than 70%, or if the NIF falls below 60, that's where you kind of try to take that breath in, for those of you who have gone to the clinic. The other thing that we look at, I think, maybe even a little bit more important than the vital capacity in the NIF, it was just how you feel. Are you waking up with morning headaches? And that is really the big one. You want to see, are you having morning headaches? Early intervention can improve compliance and improve nocturnal ventilation. So that's super important to start early. As the disease progresses, you may need to get into some wheelchair ventilation that helps keep you independent and moving. So you're not stuck bedside with your ventilator. And that, of course, could be done with a mouthpiece, which gives your face a break from whatever interface you were wearing with the bedside ventilator. And of course, if that patient who chooses to have a trach, then we can also use those same devices, those last three there, to ventilate non-invasively. So same machines, just different spot we're ventilating from. So no problem there. So how does the RT contribute to the multidisciplinary team? Basically, the RT will receive any pertinent information of your medical that would impact your respiratory status. For example, if you have COPD, that's a big one. We need to know about that. And that will help us when we actually do the assessment. Instead of doing a forced vital capacity, we'll do a slow vital capacity in that example. We monitor your vitals, oxygen, your heart rate, your respiratory rate, and your don't have that capability to measure your CO2. And of course, we're going to take a listen to your lungs, especially the bases. The bases are the tops of your lungs are easy to ventilate. The bases are a little bit harder. So we're going to take a good listen to the bases of your lungs to make sure you got good air entry down there. We measure your vital capacity. We measure your cough flow, and we take a look at your negative inspiratory force, or NIF. Next topic down we kind of explain the needed therapies once the doctor gives us the green light on that. And we want to start earlier, like I said before. Much easier to do this earlier, be proactive than be behind the 8 ball. I know for myself, I don't really think well when I'm sick, and it's good to start early. And then, of course, we communicate with the team, the physician, about what your numbers were and where we need to go with therapies there as the doctor sees it. So as we come out to the home, we're going to be checking to make sure everything is safe in the home. We'll come in. I know some patients will say, when I come into the home, like, what are you looking at? And I'm like, oh, I'm just looking to see if you have smoke detectors. And then when I ask you if they're working, of course. So I kind of look around. Long drapes are another big one. If you have a power wheelchair and you're running around with the power wheelchair in the house, unless you want to redecorate your wall, sometimes it's best to make sure the long drapes are not in the way of the power wheelchair. Also, obviously going through hallways. So we're kind of scanning things. We're going to make sure that it's a safe environment for you to bring this equipment into. We provide the initial setup of equipment. We complete that training. We kind of go over, we train the caregivers, we train the patient, everybody involved in the care will know what to do and moving forward, so to keep you safe. And then, of course, we come out and we monitor the patient monthly. We ask if there's any changes, and we relay that message back to the team, the doctor, just to make sure everything is where it needs to be. As you know, ALS is progressive, so things do change. This all helps keep you out of the hospital. Okay, so Millennium Respiratory is a family-owned business. We've been around for over 20 years. The second tab down, we keep our T to patient ratios on average of 1:40. The benefit for you is we're not stretched out so thin. We try to provide as customized service as possible. I know myself, I try to keep my phone on through the weekend. We provide on-call service 24/7. Our therapists we're out on community walks and talks and conferences such as this one. We're involved in the state respiratory chapters. The other important thing that we do is we do in-servicing for nursing companies to make sure that they know how to use their vents. Some nursing companies choose to do that, some don't. But regardless, we're going to be training those nurses in the home, or if they come to the office, we're going to be training them. Of course, that's kind of taken a back seat to the COVID crisis. So I'm sure as things somewhat return to normal, we'll start doing that again. But basically, the nurses come in and we kind of go over the ventilation equipment, the aids for clearing out the airway, so that they know how to better help you. So that's a huge benefit for them and for the patient as well. And we participate in many of the neuromuscular clinics across the country, providing the respiratory piece for the multidisciplinary team. And that's a huge benefit for patients as well, just to kind of have everything. I know some of you are already going to it, but for those of you who aren't, or maybe considering it, the clinics that provide a one-stop shopping experience, if you will, saves the patients a lot of time. So you're coming in there to the clinic and you're addressing your needs. One of the things I like to recommend is jot all your questions down ahead of time, because when you're there, you're only getting 20 minutes or so with each discipline, and it's pretty hectic. So have your questions organized so that you get the biggest bang for your time commitment there, because you guys are driving in. I know some of my patients drive 2 hours for the clinic. Your time investment there. So that concludes that portion of the presentation. And if there's any questions, I'd be happy to entertain those here. Okay, I don't see anything. There were some earlier questions. If you guys have some, I know questions come up in the home as far as what to do, what mask to wear. Definitely reach out. Your therapist is there to help you, but they're only going to know to help you if you ask them. Okay. There's a question here. Why would a patient avoid oxygen? That's actually a super, super good question. And the answer to that is, as the diaphragm weakens, and let me backtrack a little bit. ALS is not a lung disease. ALS is a neuromuscular disease that affects the diaphragm. So the diaphragm is a dome-shaped muscle that moves down and allows the air to come into the lungs. With ALS, that diaphragm is weakened and that process becomes harder. So the issue is typically, I'm going to say never, but typically with an ALS patient, unless there's some other lung disease, it's almost always a ventilation problem and not an oxygenation problem. Oxygenation is at the cellular level. Ventilation is the actual mechanical air moving in and out of the lungs. So your go-to, to answer that question directly, your go-to, if your oxygen levels are dropping, your O2 saturations would be your ventilation device. You could also get some hyperinflation therapy with your cough assist. Okay. Looks like we're out of time here. I appreciate everybody showing up and listening to my spiel about ventilation. Any other questions, you can direct those to me or your respiratory therapist. Thank you.